Hey everybody, welcome to Ask Dr. Testosterone, episode 17, starring all the way from Athens, Greece, Dr. George N. Touliatos, author of Bodybuilding, the Good, the Bad, and the Ugly. Excellent book. You can pick that book up at his website, gtool.com, gtoul.com, or on amazon.com. Doctor, you've been busy this weekend. Past few days, I've been seeing you at conferences, or what have you been up to? It seems like you've been everywhere.
Have a good day, a good month, have a nice week and a good month. Now, I was very busy because I was chosen among the Psychiatric Society, and this is very courageous for somebody who is out of the psychiatry, trying to convince them that testosterone is good for the mental health for the hypogonadal men. Because as we know, they claim that testosterone is a villain, belongs to anabolic steroids, which is basically a major androgen. Men cannot live without testosterone, and there's no substitute to this. And HRT and optimization of hormones can help in metabolic syndrome, diabetes, depression, plus the well-known cachexia, anemia, and osteoporosis. And therefore, and hypogonadism, of course. And therefore, I try to convince them that testosterone is beneficial for the depressed man who already is in depression, but he doesn't know that he's hypogonadic, because hypogonadism leads to depression. And hypogonadism leads to erectile dysfunction that leads to depression as well. So it's a circle. And psychiatrists under prejudice prescribe SSRIs that lead also to further hypogonadism. Therefore, the problem is not solved for where it initiates. The same with a urologist and Viagra and Cialis or Levitra that do not supply libido, that they don't produce libido, but just a blood supply to the penis. Therefore, it is not a vascular pump, nothing more. No libido, no sex drive, no will to have an intercourse. Yes, and I was a biopathologist among a plethora of professors of psychiatrists, and yes, there was a good feedback and question. And this is very hopeful, and I hope, and also the major brand of testosterone in Greece is called Norma, that produces testosterone anthate, approached me to become an ambassador. In order to convince people. Yeah, they came to my office and they found me also in the Congress. So we want to build a testosterone andecaonate, aka Nebido or Avid, but in Greek version. Because it's very expensive, the German brand. It's almost $120. Therefore, we can produce this in half of price and have the monopoly. Anyway, we'll see. The thing is that they shouldn't be aware, physicians, of testosterone, and it's a fact that we bodybuilders give steroids and testosterone even a bad name through the abuse. Because each drug has a side effect, and what differentiates a drug from a poison is the abuse, the chronic or the dose abuse. Therefore, under small doses, they are very effective androgenic anabolic steroids, and in particular testosterone, that is the most familiar among all the AAS. It's a familiar hormone, it's not synthetic derivative, and it's a non-toxic, and it's very, you can live without testosterone, but you can live without GH, for instance. Therefore, this is what differentiates men from boys.
So
plus there was sorry?
Where was this conference held?
It was in North Greece, in close to the capital of to the second largest city in Salonika, but it was in a place called Chalkidiki. It was almost 400 miles far, and I have to drive back and forth, so almost 1,000 miles within 3 days was 6 hours complete driving. Yeah, it was nerve-wracking, but I was really excited. I took a video, and yes, yesterday also I was live on air. As I was returning, they called me from a radio station to talk about, there was a major steroid bust, and my task is to speak about, in general, steroids in society, and as a physician and former abuser, as an athlete. And the same today, yes, I will be hosted in tonight's broadcast about the same topic, but I try, to keep balance. I mean, I have walked the talk, and we should preserve health most of all, but people that will to undergo this, they have to monitor their health. Of course, it's forbidden for IOC and Olympic Committee sports, but bodybuilding is a special case because there's no doping control. Yeah. Apart from the FBB world champions that they're supposed to be checked. But in general, the majority, 90% of people are not athletes because athletes, obviously, they get banned. Yeah. They play this hide and seek. Therefore, they are ordinarily people who want to improve their relationships, their self-esteem, their self-confidence, the way they look, and they just want it for performance-enhancing purposes, and with recreational use.
Well, thanks you obviously gave up a lot of your time, your energy this weekend.
Yes.
Probably didn't sleep much, probably missed a workout.
Yeah. I mean, I have to... the last week I couldn't go to the gym, and for me I was a gym rat, and this is very.
I know, dude. You must be going out of your mind. I would be. Oh well, we'll get it back. But you're serving the greater good. You're getting the message out there, and especially with the psychiatric profession.
Yes.
Hopefully you're starting to change some attitudes.
Yes, the old mind, and the very close-minded, and they have to think outside the box. I mean. Some few steroids are in the pharmacy store. They do not use them. They prefer to use EPO instead of anabolic steroid that will increase EPO. Yeah. They do not use steroid for osteopenia, but they use vitamin D3 and calcium. They do not even use for muscle wasting, but they give some some supplementation. Therefore, this is crazy.
Yeah. Well, you started the dialogue. Maybe they're going to things will change. They'll open up their minds. They're going to start looking into.
Recallings is very important to this.
Right. But I mean, you're helping anything any of us can do, you in the medical profession, to take some of that stigma away.
Well, what you do with Dr. O and Dr. T, myself, is very good for open mind and introduce this taboo subject under scientific perspective into the masses. Yeah. Dr. O and perhaps some physicians that watch us, they have to realize that this is a reality, and you to think it, scientifically. Okay. Not, yes.
Well, we've got some great questions. These questions are starting to come in mostly from comments under the videos on YouTube, which is great. So everybody, you can do that. Leave your questions right here under the video in the comments, and Dr. T looks at them, and he tries to find the best ones that'll apply to the most people that are challenging, But so far, you guys have come up with great questions. Number one, Doctor, what about testosterone while on beta blockers? 3.75 milligrams in blood pressure tablet Ramipril, 2.5 milligram. So is it okay to take those at the same time?
Yeah, beta blockers are mainly for LVH, for left ventricular hypertrophy. Now, the other drug he uses, I checked it out, and it's AC inhibitor, angiotensin converting enzyme inhibitor. This is a basic class, a major class of antihypertensive drugs. They causes vascular dilation and drop in blood pressure. So this guy uses medications for blood pressure and left ventricular hypertrophy that also leads to high blood pressure in the long term. What he uses, testosterone is good. As for TRT, and as long as it is within range, for instance, up to 200 milligrams per week. But I did not suggest to combine with anabolic steroids because and a very high intensity of training, because this induces thickening of the heart as a reaction to the muscle. Okay. He has to check his blood pressure and be within 120/80, the highest range, okay? Yeah. Because if you are already hypotensive, you cannot either train, okay? You feel so fatigued, drained, and sluggish. And yes, he has to monitor daily his blood pressure, and once in 6 months, twice a year, with an echocardiogram, his heart, his LVH, how it proceeds.
Okay. Next question is something you would not have to worry about, hair loss, because look at all that hair on your head. That is a thick, full head of hair you have, doctor.
Genetic.
So this guy says, my hair loss while on TRT, I only take 250 of testosterone per week. When I use saw palmetto, I get a lower back pain, and I feel like I'm not getting any benefits from my testosterone shot. So please, doc, I need your opinion. So saw palmetto is supposed to help reverse that DHT conversion, or what's he talking about?
This is the supplement that is supposed to block the reduction of testosterone to DHT. It's a classic supplement. I remember it for the last 20 years. Now, I'm not sure if it's the same effective as the anti-androgens, 5-8 reductase inhibitors, dutasteride and finasteride. If you use 5-8 reductase inhibitors, you do not observe a major decrease in strength because DHT is deactivated in muscle through another enzyme. But what DHT through the estrogenic effect may oxidize some fat and may you feel harder and more dry because DHT is antiestrogenic, like masteron or proviron also. Now this guy, obviously he's genetic predisposed because he has this his hair thinning.
Yeah.
And this is something personalized because according to our grandfathers, from mom and dad, because like myself, I do not have experience, even the fact I'm using both DHT and testosterone in the form of proviron and testosterone.
Yeah.
I do not have hair thinning. However, back when I was abusing steroids, maybe I had a hair thinning in the occipital area, but I wouldn't say it was androgenic alopecia severe, you know.
Right.
As this here we have the temporal lobe. This is a characteristic of a man, okay? As we age, it goes deeper.
Yeah.
Yeah. So
but he's only on 250 milligrams testosterone a week. Would that normally cause hair loss in somebody who was not prone to hair loss?
If you're prone, yes, because 250 a week is just above the range of higher TRT. And once a week, mind that it spikes. Boom, 250 spikes. So if you do 125 twice a week, is a less spike. Okay, this is the importance of a small and the more frequent because it blasts one, okay, and it gives an increase. So I suggest to split the dose, or even to 250, you can do 5 of 50. Every day 50.
Okay.
Monday to Friday. But I'm not sure about this lumbar pain, his low back pain. I never experienced something like that.
From saw palmetto, I've never heard of that.
No, and I think saw palmetto is even weaker for the hair. For prostate, it may be more prominent, but for the hair, I never heard of it. Minoxidil and ketoconazole that block DHT in the scalp are more effective locally.
Yeah. I mean, if I was losing my hair, I'd want to use more than some supplement I picked up at GNC, you know?
Yeah.
Okay, this next question, I don't know if this is pretty complicated for you to answer because seems like it might be. What about a 47-year-old bodybuilder wants to compete? What should the best blood test and heart before start at cycle? So
okay, this is a good question, a basic one.
Yeah.
And I love this kind of question dealing with prevention. Now, at his mid-40s, he should focus on his prostate also, okay? His homocysteine, very important for the cardiovascular system. His LPA also, because it gives deeper look about the cardiovascular disease. Of course, his lipid profile, HDL, LDL, total cholesterol, and triglycerides. Also, we need the GFR, urine, urea, and creatinine for the kidneys. ALT, AST, GGT for the liver. Of course, a CBC for his hematocrit. Okay, and we need a PSA for his prostate and maybe free PSA. And if he wills to proceed into growth hormone, he can do the tumor markers CEA, which is the major one, AFP, which is alpha fetoprotein, and CA 19.9, which deals with the gastrointestinal system, and the liver and the pancreas and the bowel and the small intestine also. Another thing is to perform, of course, an echocardiogram, a triplex or ultrasound of the heart.
Yeah.
All right, and some also triplex of the carotid arteries because they resemble. They say cardiologists believe that if you have clean carotid arteries, you're more likely to have clean coronary arteries as well.
Yeah. I mean, if you had plaque in one, wouldn't you probably have plaque in the other?
In the coronaries.
I mean, if you have, would you show plaque in the coronary?
The carotids resemble the coronaries condition.
Okay.
Of course, quit smoking if he does. Okay, alcohol. This is well known. As an athlete, you must.
You tell everyone every week to quit smoking, so good for you.
Oh, but listen, the athlete that smokes sabotages himself.
It always freaked me out when I would see, European bodybuilders especially, they'd come over to compete, and I'd see them back of the venue just smoking. Like,
this is due to two reasons. Maybe this is pot in order to relax. Now, it's well known that smoking reduces appetite. But it's not a smart idea. You can use ephedrine for this.
Right.
Or another herb called hoodia. But, yeah.
Okay.
But marijuana is really effective to chill out.
Yeah, I mean, tons and tons of bodybuilders smoke marijuana.
It gives you gyno, though, through prolactinemia.
Even if you're on testosterone?
No, but prolactinemia, you have to lower it with drugs.
Okay. So as long as you're on some test, you're good.
Yeah. Okay. I had a girlfriend from Norway. She was using pot in order to sleep.
Yeah, it'll knock you out, definitely. I'd rather see somebody do that than, take 4 shots of whiskey or something. Okay, this one, English not his first language, but I think we can understand this. I like to be able to train very much indeed and very frequently, same body parts, as part of my other activities also. So will omega-3 intake by fish, mackerel after training? I eat only once a day. Make this possible even though I will get less benefit seen from a muscle building perspective. If eating fatty fish after training, then as the inflammation decreases and so less muscle is being built. In the past, I trained all muscles every day with no overtraining symptoms, and then I was eating a lot of fish oil. This could be the reason no overtraining occurred. So fatty fish is anti-inflammatory.
Okay, this makes sense through the theory of William Llewellyn, the arachidonic acid, and that supports muscle inflammation, while the anti-inflammatory omega-3 fish oil, EPA, DHA, block this. Now, the first mistake is that he eats once a day. This is...
Yeah, what the hell?
Yeah.
And he was training every body part every day.
Yeah, this is completely wrong, the wrong approach. So he has to split those calories in 5 different portions. Yeah. Stimulate BMR, okay? Avoid insulin spikes, have constant supply of energy, okay? IF doesn't work with bodybuilding. IF leads to muscle catabolism and drop in BMR. Now, eating a fatty fish and generally eating something fatty after the workout hinders protein absorption and utilization. Therefore, it's wiser to use other kind of fish that are not fatty. I do not know in English the names, but we have in Mediterranean Sea plenty of fishes that they are almost 90% of water and pure protein, nothing else. Yeah. He can also use albumin, for instance, egg whites, okay, or whey isolate.
Oh, I mean tuna, white albacore tuna is
tuna is also very low in fat.
Tilapia, a lot of guys eat tilapia.
Yeah, but tilapia, they blame them for feeding them with omega-6 inflammatory.
Ah, geez. Yeah, I don't hear a lot of good things.
Otherwise, they are perfect because they are very low in fat. Yeah. And short fish is plenty in mercury, okay, which is a heavy metal. Yeah. Now, so yes, it will block his absorption. Therefore, having a salmon right after the workout is not a good idea. Maybe you can have a salmon as a lunch before, or not right after a workout. Right. But it makes sense that too much of omega-3, and actually too much of omega-3 fish oil above 6 grams a day, it will sabotage your coagulation, and maybe you have prolonged bleeding time.
Oh, wow.
It works as an aspirin, but aspirin works... aspirin doesn't work for those who have enzymatic deficiency G6PD. Okay. But fish oil is more healthy. Yes, it blocks prostaglandins and platelet aggregation. So I suggest him to transfer this meal before the workout. If he trains in the afternoon, in the evening, he should have it for lunch, for instance, instead of a dinner.
Is there any special time that we should avoid it? Like the post-workout meal, obviously you explained how a fatty fish meal would block the protein absorption.
And will sabotage your...
It will, because of the anti-inflammatory. Is it very bad to have that much anti-inflammatory effect going on an hour, 2 hours after you train when you want
Actually,
that?
it's good to have oxidation process right after the gym, because this will speed up the repair mechanism.
Okay.
We don't need too much of anti-inflammatory and antioxidative molecules right after. For instance, too much of vitamin E or vitamin C right after the workout.
Right. Okay.
Because we need this kind of damage that is the stimulus for repair, along with rest, supplementation, and also food, nutrition.
Okay.
So what I suggest is, if you want to use an aspirin, use it as an neck stack on an empty stomach instead of post-workout. And it has to be a window of some hours, for instance, 12 hours, 8 a.m. or 8 p.m., in order not to interfere with the inflammatory processes.
Okay.
Because prostaglandins, through the arachidonic acid theory, they boost the muscle inflammation and etc. repair.
Okay. Next question. We've been holding off on this one because it is one of those long questions. So sit back and relax, doctor, as I read you this next question. Do you have a snack? Here we go. I started HRT in December. I'm 38 years old. Test was at 274. Free test was 6.9. Estradiol was 11.5. Reference range 7.6 to 42.6. Doctor put me on 200 milligrams of test-cypionate, 200 milligrams DECA to help alleviate joint issues with my knees, 8 CG, and 2 milligrams anastrozole per week. First 10 weeks felt like a new person. I started noticing some mild joint discomfort in shoulders and elbows, but nothing horrible. Joint issues with knees was pretty much gone. Next 10 weeks kept everything the same but dropped the DECA. Over those 10 weeks, I started experiencing more significant joint pain in my shoulders and elbows, something I had never experienced before, to the point where it was severely limiting my workouts and normal activity. I was also dealing with lethargy and fatigue. After reading around, it looked like my estrogen was possibly crashing. I dropped the anastrozole down to 1 milligram per week, and then eventually stopped taking it altogether. I also started back up with DECA to help with the new joint issues. I just got another round of blood work done, 2 weeks since I had any anastrozole, and 1 week since I added back in DECA at 200 milligrams per week. And my estradiol came in at 11.3, which is slightly lower than when I started HRT. Does it seem plausible that crashing E likely caused the joint issue? Is there an estradiol number that would be considered optimal? At a minimum, it seems like I should continue avoiding anastrozole for the time being and monitor my E levels, or just drop to a much lower dosage. I have a call in with my doctor next week to discuss, but wanted to get your opinion as well. His doctor's not going to know the answer to this anyway. So
it's a long story.
Yeah, but I'm sure you know more about this than his doctor.
I think this guy is obsessed with AIs, aromatase inhibitors, estradiol, joint pain. He's very worried about it. Now, what was his testosterone dose? 250?
Doctor put him on 200 milligrams test-cypionate a week.
Okay, 200 milligrams per week is not too much, and I believe if you split it to twice of 100 milligrams, you can avoid spiking of estradiol. But because he has issues with joints, we need some estradiol, for instance, up to 50. If you lower it back to 20, he will have issues because estrogens are linked with water retention and joint lubrication. Therefore, he shouldn't be obsessed with using aromatase inhibitors and lowering estradiol unless he observes some gynecomastia and soreness and tenderness in his mammary gland, his nipple. Therefore, he can split his TRT dose. Also, DECA improves lubrication up to 100 milligrams, 50 milligrams or 100 milligrams. I suggest him to use maybe half a milligram per week of anastrozole if necessary, but if you split the 200 milligrams twice of 100 milligrams, then I do not believe that it's necessary to use an aromatase inhibitor. Unless he uses DECA, maybe he needs half or 1 milligram per week.
Okay. Well, it sounds like he is going to keep using DECA.
Now, the optimal range for E2 is between 20 and 50, 20 or 40, because too low will crash your E2 and your libido, will kill your libido. 3-digital E2 above 100 will also lead to pure duration. But men need E2, so estrogens are necessary for healthy sex drive, as in women, they need also some androgens, women, for a healthy sex drive. Therefore, we both share our hormones for a healthier sex drive.
Okay. So the optimal range again for estradiol should be what?
It should be 25 to 50.
25
okay,
to 50.
But in his case, I wouldn't say that he should worry if it's, for instance, 50 or 60, the highest range of some laboratories.
Okay.
You can use the decan alongside, okay?
Yeah.
And, as far as he doesn't observe some serious edema or gyno, he shouldn't be so much obsessed about it and paranoid.
Okay.
Because as myself, you get trapped in labs and in papers and numbers. You get freaked. You're freaking out.
Yeah, I know people that are so obsessed with, they know more about drugs than, I'm not going to say any experts, but it's crazy how much
Being yourself.
some guys do.
This is not leading anywhere. It's paranoid. Ups and downs, and it's crazy.
Let's wrap it up with an insulin question. Everyone loves insulin. Okay, what would be a good scheme to use insulin long-term, but without any desensitization issues toward insulin? I heard of 12 weeks on, 4 weeks off quite often. But does it really minimize the risk of being insulin insensitive and still have the full benefits? And how high would you rate the risk for triggering cancer growth at this moderate IGF-1 increase? Oh, wait, is he talking about MK677?
I think so, yeah.
Okay, I'm sorry. So he's actually talking about MK677, a SARM.
Okay, now,
not insulin.
if the question was referring to insulin, I'm going to answer that there is no problem with this thought. And as a matter of fact, exogenous insulin will give you more insulin sensitivity and will prevent pancreas from overloading or overworking. So it will give a rest to pancreas.
Yeah.
Now, about Thomas O'Connor had an extensive interview and show about it. If this is a GHRH, growth hormone releasing hormone peptide, okay, it's supposed to elevate endogenous GH, therefore to be safer for the IGF-1, to be not so high and spiked, because years elevation of IGF-1 may be linked with cancer and cellular proliferation. In this way, secretagogues, growth hormone peptides, fragments are safer in terms of cancer prevention, but of course they are less effective in terms of muscle growth. Maybe they are more effective for anti-aging purposes and fat burn, because growth hormone in the low stages does anti-aging, then it goes fat burning and goes muscle hypertrophy according to the dose. So because secretagogues boost a little bit of growth hormone endogenous, we're not expecting something more than rejuvenation and maybe some fat burn. But Thomas O'Connor said that it leads to cellular edema, okay? I think so in his show, yeah, he supported that it leads to some edema, as growth hormone also does. Yeah. Yes.
So he's concerned that this MK677, which I stand corrected, it's a peptide, not a SARM. So
no,
is it notorious for causing insulin sensitivity or insensitivity?
Now we know that growth hormone
insulin resistance.
Growth hormone it leads to insulin resistance, but growth hormone itself, not the secretagogues that release some of the endogenous growth hormone, okay, during night. Of course, it's very notorious for boosting ghrelin, which is the hunger hormone, the appetite hormone, and stimulates, eating through the fundus, the upper area of the stomach, okay. On the contrary, leptin from the adipose tissue brings anorexia and satiety.
Yeah, it makes you feel full.
So yes, the major concern would be appetite, boosting appetite and hunger.
Okay.
And I have noticed myself with sermorelin, actually. I had the urge to eat something half an hour afterwards. It's crazy, eh?
You probably ate Chinese food, because then you get hungry a half hour later. Well, that's the old joke. Okay. So again, MK677 is what? Because I'm not that bright. It's a peptide?
It's a GHRH peptide, secretagogue.
Okay.
It's
the
a
only
fragment.
one was GHRP6, which is...
It's a certain sequence of amino acids that release endogenous growth hormone from the anterior pituitary.
Okay. And a lot of people use this as an alternative to actual growth
Yes,
hormone?
because it's cheaper, and doctors also prescribe it because it's a safer option. And yes, of course, the growth hormone is much more potent, more expensive.
Yeah.
It's the real deal, and the other is just a small fragment of this.
Right. Okay. Well, Dr. Touliatos, thank you for not only today's show, but for giving up your entire weekend to educate, hopefully, some members of the psychiatric profession about what androgens can and can't do, and the role.
It's about time for this, yes.
Yeah, I mean, it's, you know, there's not many people getting the message out there like you and Dr. O'Connor. So we, on all our behalf as men.
You know, because Thomas and myself serve the sports.
Yeah.
It has to do having education about sports and being an athlete as well, because, you know, being a theoretical, going by the book, you're missing half of the truth.
Right. Well, I mean, you wouldn't be able to do this show and answer these questions if you hadn't walked the walk, you know.
Sure, yes. And in order to love this field and be educated constantly, you know, and give my all, I mean, I dedicated my life to the education and to have this kind of career, to be the doctor of bodybuilding and help. I mean, as a doctor, I support health. Therefore, if you want to do something, do it more safely.
Yeah, cool. Well, we all appreciate it, Doctor, so thank you so much. And everybody, keep your questions coming in. If they're not too long, we'll use them. But if it takes me 10 minutes to read the question, guys, that's probably too long. Try to keep them a little briefer. But we do enjoy your questions. Doctor loves a good challenge. He likes to be able to help everybody with things that are going to apply to a lot of other people around the world watching and listening. So thank you, Doctor. Appreciate today's show, as always. And everybody, again, one last time, check out the book, Bodybuilding, The Good, the Bad, and the Ugly. Available on gtool.com, gtoul.com, and amazon.com.
And on July issue, I'm having the roid rage.
Oh, yeah. Roid
It's very
rage.
notorious and misunderstood topic that Connor also developed it.
Yeah, that's
Yes.
right. The July issue of Muscular Development Magazine.
Yes, I have the roid rage.
Dr. T is going to address roid rage in that one. So check that out for you guys who maybe you've had some roid rage or you're thinking about
You know,
worrying about
Dr.
having
Hulk,
one. Yeah, the Hulk was the original roid rager. But that was gamma radiation. That wasn't steroids. All right, everybody. Thank you for watching Ask Dr. Testosterone. We appreciate it. We'll see you next time.